Dear students, welcome back. In the previous session, we have discussed about kinematics and kinetics of gait. So, we have discussed the kinematics in the sagittal plane view of the lower extremity during gait. So there is still another group of components of gait usually considered in a kinematic analysis. So those components are called as determinants of gait. The determinants represent, so what are these determinants are going to do? The determinants represent adjustments made by the body. So the determinants represent adjustments made by the body that help to keep movement of body's center of gravity to a minimum. So that is the main function of this determinants. So these determinants represent adjustments made by the body that help to keep movement of the body's center of gravity to a minimum. So there are 6 determinants, okay, or there. One is lateral pelvic tilt, okay, in the frontal plane. We are going to see lateral pelvic tilt in the frontal plane, knee flexion, knee interactions, ankle interactions, pelvic rotation in the transverse plane, and physiologic valgus of the knee. So these are all the determinants of the gait. Okay, the determinants are credited with minimizing the up and down. So up and down and side to side, up and down and side to side movements of the center of gravity. Here this indicates the COG, center of gravity, and producing a smooth sinusoidal curve, and produce smooth sinusoidal curve. Okay, so the order of presentation of determinants that follows is based on their function and is not necessarily related to the order in which they appear in gait. Okay, so here in this pic you can see the vertical displacement of body's center of gravity. So here this is the position of heel strike. Okay, so the vertical displacement of body's center of gravity produces a smooth sinusoidal curve in normal walking. So the lowest point in the curve is during the period of double support. The highest point in the curve coincides with the mid stance. So this is the mid stance position. It is having the COG is the at highest point in a gait cycle, when the trunk is directly over the stance extremity. So the drawing shows the lowest and highest points in the curve. Okay, yes. Now we will move on to the actual determinants of gait. So I have mentioned the 6 determinants, isn't it? Out of 6, the first 4 determinants. What are the first 4 determinants? One is the lateral pelvic tilt. Okay. Next one is knee flexion, knee, ankle and foot interactions. So knee interactions and ankle and foot interactions. So all these 4 are the first 4 determinants help to keep the vertical rise of the body's COG. This will help in vertical rise of the body's COG to a minimum. The 5th determinant prevents a drop in the body's COG. What is the 5th determinant? Here the pelvic rotation in the transverse plane. Okay, while the 6th determinant reduces the side to side movement of the COG. Okay, the sixth interaction is the physiologic valgus of the knee. Now first we are going to discuss about the lateral pelvic tilt or the pelvic drop in the frontal plane. Here we can find the this one is the pelvis, and the dotted lines is the actual position, and this one is the tilted pelvis. Now we are going to discuss about it. So in a single limb support, unilateral weight bearing, the combined weight of HAT and the swinging leg must be balanced over in the one lower extremity. During this period, the COG reaches its highest point in the sinusoidal curve. Okay, that means in the previous session we have seen normally the COG is going to shift upwards to balance this HAT and this swinging limb. So all these together are going to balance on this point. Okay, so the lateral tilting of the pelvis, that is pelvic drop on one side of the unsupported extremity, keeps the peak of the raise lower than if the pelvis did not drop. Okay, because the drop produces adduction of the stance hip. So the tilting of the pelvis is controlled by the hip abductor muscles of the stance extremity. So the same thing we have discussed in unilateral stance, isn't it, at the hip joint? The same function again we are going to discussing here to raise the COG, that is the vertical increase of the COG. Okay, this increase is also not so much of vertical increase, so which is going to help to balance the entire HAT and the swinging limb. For example, pelvic drop on the right side swing extremity is controlled by the isometric and eccentric contractions of the left hip abductor muscles. Okay, next if you see the knee flexion at the mid stance when the COG is at the highest point represents another adjustment that helps to keep the COG from raising as much as it would have to if the body had to pass over a completely extended knee. So this knee flexion, which really helps again to increase the COG at the highest point, that is mid stance position, and this increase is going to be present till when this flexion is completely reached to an extended knee. Okay, so now we will move on to the knee interactions and foot interactions. Combinedly we can call it as knee, ankle and foot interactions. So movements at the knee occur in conjunction with the movements at the ankle and foot and are responsible for smoothing the pathway of body COG so that it forms sinusoidal curve. Combined knee, ankle and foot movements prevent abrupt changes in the vertical displacements of the body COG from a downward to an upward direction. Okay, the change from a downward motion of the COG at heel strike to an upward motion at foot flat is accomplished by knee flexion, ankle plantar flexion and foot pronation. These combined motions serve to relatively shorten the extremity and thus prevent an abrupt rise in the body COG after heel strike. Okay, so this is the main determinants that is called as combined action of knee, ankle and foot interaction. So combined action of these knee, ankle and foot helps in abrupt increase or decrease of this COG. So all this combined action helps in forming a smooth curve called as sinusoidal curve. Next determinant of gait is the forward and backward rotation of pelvis. Forward and backward rotations of the pelvis in the transverse plane accompany forward and backward movements of the lower extremities of the gait. Okay, so forward rotation occurs on the side of the swinging extremity. So here this is the swinging extremity, so we can see the forward rotation, that is left side. Left one is swinging forward to keep the limb in front, so there is a forward rotation of the pelvis we can see. Okay, so this forward rotation occurs on the side of the swinging extremity with the hip joint of the weight bearing extremity serving as the axis for the pelvic rotation. Okay, so the pelvis begins to move forward at pre-swing and continues as the swinging extremity moves forward during the initial swing. At the point of maximal elevation of the body's COG in mid stance, okay, the forward pelvic rotation has brought the pelvis to a neutral position with respect to rotation. So once it reaches to again this mid stance, again this pelvis is coming to the neutral position. Why? Because that is the highest point of the COG. Okay, next, forward rotation of pelvis continues beyond neutral on the swing side through the terminal swing to the initial contact. Next, the other one will move. Okay, so the other limb starting the swing and it continues to move. Okay, so forward rotation of the pelvis continues beyond neutral on the swing side through the terminal swing or to the terminal swing of the initial contact. Okay, next, the total amount of rotation of the pelvis is small. Total rotation of the pelvis is small and averages about only 4 degrees. And averages about only 4 degrees on the swing and stance sides for a total of 8 degrees. Okay. So the result of pelvic rotation is an apparent lengthening of the lower extremities. So apparent lengthening of the lower extremities. The swinging lower limb is going to lengthen in terminal swing by the forwardly rotating pelvis. And the weight bearing extremity is lengthened in pre-swing by the posterior position of the pelvis. Okay. In the pre-swing, this one is also lengthening. So the thing happened here is the result of pelvic rotation is an apparent lengthening of the lower extremities. One is in the swing phase which is going to lengthen, as well as another one is in the stance phase that is pre-swing stage. In that also both the lower limbs are lengthened here. Therefore, both the stance and swing extremities are lengthened as the COG descends to its lowest COG level in the period of double support. Okay, the relative lengthening helps to prevent an excessive drop of the COG and maintains the COG at a higher level than would be possible if no pelvic rotation occurred. Okay, so pelvic rotation functions to minimize the depression of the COG. What is the main function? The pelvic rotation functions to minimize the depression of the COG. while the first two determinants function to minimize the elevation of the COG, and this one is going to minimize the depression of the COG. Next determinant